Good morning. We are going to go ahead and get started. For anyone who doesn't know who I am, my name is Cassie Sturtz, and I am one of the managers who works with CareOregon in our behavioral health department. And I am going to be hosting you all through today's learning series. This is day 2, so welcome everyone. I see some familiar faces from last time and some new faces, which is even more exciting. So we're so happy to have you here. So first, we want to just start by thanking all of our HealthShare Plan partners for making this event possible, for all your hard work leading up to today. I also want to give a shout out to all the folks in our Youth SUD task force. If your name is on this slide, could you please raise your hand? Thank you so much. We can give them a round of applause. They have been meeting every week, every 2 weeks since February to help plan this event. So a lot of hard work and conversation has gone into this. One of our intentions of this learning series is that it gets paid forward, so that the knowledge that you get today, all of the slides that will be available to you today are for you to take back to your teams, for you to pass around, for you to send to whoever is on your favorites email distribution list. Please get this information out there. We also have 2 more sessions coming up. So we've got the 10-19 and the 11-9 sessions. If you haven't already registered, we are on a wait list, but please add yourself to the wait list so we can let folks in as able. All of the presentations and resources are going to be available on Basecamp. You should have gotten what might appear to be a spam email from Basecamp. It is not a spam. Please accept it so that you can get onto the platform. That's where everything will be. There's also some cool features on there where we can message each other, we can ask questions, get answers, all of that good stuff. If for some reason you did not receive the Basecamp email or you declined it, please reach out to Kayla. She's also right over here. So if you need anything from her, please let her know. Here's just like a brief this is what Basecamp looks like when you log on. CMEs. There's a lot of information on this slide, but essentially things to know here. At the end of every day, during closing remarks, you'll get an email with a link to the evaluation, which will then get you your CMEs. One point to be aware of, certificates will not come out until the end of the last learning series, regardless of how many you attend or not. So just be aware you're looking at November before that certificate actually arrives. And again, Kayla is your gal if you have questions about CMEs, or if for some reason you're not getting the email with the link at the end of the day. So just a little bit about why we're here and what really drove our youth task force to create this learning series. We know this is just going to be a bunch of statistics, and I'm going to kind of summarize for you all, but I think the main points to think about and take home really are that we know that overdose rates have continued to rise for the last 2 decades, and we know that for adolescents, they have doubled since 2020. We also know, and evidence-based guidelines show us that medication is one of the most effective interventions, and we also know that youth receive access to medication at 1/10 the rate of adults. We also know that the transition from fentanyl to bup is much more challenging than the transition from other opioids to bup. And for those youth who do get access to medication, their ability to maintain that access ongoing is extremely limited. And folks are often encouraged to stop taking medication in order to do lots of things, access services, or just that non-access to the ongoing prescriber. And then, of course, we're all familiar with the unique risks that youth are susceptible to, whether that be social pressure, risk-taking, peer approval. So we know that these also impact their continuing with medication or not, and whether or not they may be at further risk for an overdose when they return home. So all of those statistics really helped the Youth SUD task force focus in on youth as a priority population and begin to think about what we could do or what we could implement in our community to help folks in this area. And one of our main goals is really to think about how to build a Youth SUD continuum of care in partnership with you all, and how we want to address those increasing rates of fatal and non-fatal overdoses for our youth in our communities. And this learning series is one way we hope to do that. We have a packed day ahead, so lots going on. We are going to first start out our morning with an amazing panel of folks from our community here in the Portlandia room. After that, we'll have a quick break and we'll head into our first breakout sessions. Again, we'll have a break after that, where we'll come back into this room together to have a joint session and some lunch. And then this afternoon, we'll have our second breakout rooms, and then we'll wrap up for the day. So with that, I would like to invite our panelists up to the stage for this morning's panel. So if y'all just want to come join me on the stage, we'll take a second to get set up. All right, everyone. If I can bring you back, we'll get started again with our panel. Thank you so much. Okay, I'm first going to start with just having each of our panelists introduce themselves and tell us a little bit about how they're connected to youth substance use disorder work in our metro region. So I'll just pass down.
Okay. Hey everybody, my name's Tony Vezina. I'm the executive director of 4D Recovery. I'm a person in long-term recovery. I've been sober a little over 11 years. I celebrate 11 years this year. Let's see, I partied a lot as a kid. I got in a lot of trouble. Eventually got sober at 27 with a little nudge from the judge. And then, went to community college, and then just got involved in 4D really early on. And we provide recovery services to young people. Started off serving 14 to 35-year-olds together as a group. That was a bad idea. We're gonna help everybody, do everything for everyone. And then as money started to flow for peer services, I'm sure some of y'all know that, we began to tease out some of our services now. 4D serves 14 to 17-year-olds, youth and families, and then 18 to 35-year-olds. We have about 100 staff across the Tri-Counties. We help hundreds of people every day overcome substance use disorder. So that's how I'm connected.
Good morning. My name is Katie Strawn. I use she, her pronouns, and I am the site medical director for the Multnomah County Student Health Centers across the county. Ways that we are connected with any youth in Multnomah County K through 12, and not only offer primary care services, but also episodic and some other different intervention, mental health, counseling, et cetera, for youth. And because we are part of the health department system, but as our own separate unit, we do have the ability to be nimble and to bring interventions that can potentially impact our youth, particularly ones with substance use disorder, and are looking very closely at how to be innovative and work with youth in the county. But I'll talk a little bit more about some of the things that we're doing, but certainly working on the prevention and education side of things, as well as doing some harm reduction practices.
Hi, my name is Stacey Mahoney. I am a clinical social worker and drug and alcohol counselor and school therapist at Harmony Academy. Harmony is one of our state's 2 recovery high schools. And recovery high schools are a place for young people who have really already had experiences and challenges with substance use affecting their lives pretty significantly, and returning to their comprehensive high school is just going to create additional triggers or challenges for them to pursue their education. So it's a space that supports their whole self, whole well-being, completing that high school diploma while getting supports and resources to maintain their recovery efforts.
My name is Brook Sanders. I use she, her pronouns. I'm connected because I work with Youth Era and I provide recovery-specific youth peer work. I work with 14 to 24, focusing on helping them learn how to engage in the community sober and have fun doing it. And finding different avenues for them to grow and move and meet their goals and advocate with all of the community partners.
So our first question was, how do you all think that the Youth SUD workforce might be improved? I don't know if anyone wants to start.
Yeah, so there's a lot of challenges to workforce in general. I'm sure everybody here is aware of that. One thing that I do just want to applaud today is CareOregon. Can we give a shout out to CareOregon? I've seen, me personally, I'm not all the way across the state, but I've seen CareOregon really reach out into the community and go and find solutions to problems and partner with agencies and stuff. And I really appreciated that as a CCO, especially because they have all the money. So it's nice to see that. I think first, and foremost, we need a plan and a strategy across the state for addressing behavioral health. I'm also the chair of our state's Alcohol and Drug Policy Commission, and we have, a strategic plan that's focused on adult care mostly, and that had a supplementary document called the OHSU Gaps Analysis that identified we were 50% under capacity for prevention, treatment, recovery services across the state. Kind of detailed some of the core components we need to invest in if we're going to move the needle, no pun intended, at this thing. And so I think we need a plan, right? And to accomplish our goals, and something that we can all move towards and say, okay, we're making progress, right? And so I think a first step is to begin to hold our elected officials accountable to look at adolescent services and to make investments, even if it's going to take time to get a workforce ready. Economically speaking, if there's money in the system, there's opportunity for expansion, and programs, agencies will naturally adapt. They'll increase rates. I think we've seen pay scales go up in the last couple of years thanks to the infusion of the cash naturally as we compete for workers in the system. And that's been really great to see, especially for my staff, me personally. And so that's what I like to see. 4D right now, we're trying to push a bill this legislative session that would put $10 million into prevention work, $10 million into the SUD continuum of care for adolescents and family, and then also develop a strategic plan for adolescent family care that would have recommendations for the 2025 legislative long session for our legislators to make strategic investments. So that's kind of how I see how we expand the adolescent family SUD services, especially for workforce.
I agree with everything you said. So I think first and foremost, what you really highlighted, and not to sound crass, but money. I mean, money is going to help a lot because not only can we expand our workforce, but we can invest in other strategies that help us to understand how to work with youth in a way that is youth-friendly and is evidence-based. From my lens as a healthcare provider, one of the things that I think we really need to look at and already we are alluding to the fact that there's very little ability for youth to access services, medication-assisted treatment services. And part of that is because we just simply don't have good guidelines out there that are focused on primary care. We do have primary care specialists, we have pediatricians, but largely in the community, very few of them have access to the resources and the knowledge that they need to offer these services to youth. And I think there continues to be judgment and stigma within the medical community that, particularly for youth, is focused on abstinence-only discussions rather than non-judgmental treatment discussions and support. And really, I think this is such a multifaceted issue, and it comes from so many different places that are so much bigger than just someone using drugs. It's what's happening in the home, what's happened in their past, the trauma that they've experienced. So investing heavily in mental health services. We are in a mental health crisis, as everyone in this room I'm sure is aware. And not only is the crisis that acuity continues to rise, the issues that we're seeing with our youth in this state continue to be more complex. Not only that, but our mental health resources continue to decline and continue to be stretched and continue to have burnout and continue to be underappreciated for the amazing work that they do in our community. So without really tackling this from so many different lenses, whether that's investing more in the social services that we have out there, and that's, food insecurity, housing insecurity, the things that we see every day around us in Portland, this is going to continue. And we won't be able to prevent the issues that are going on with our adolescents. So really tackling it from all ends, investing heavily, and really making sure that when youth do need the treatment, that they can get that in a place that's considered youth-friendly, which there's pillars of youth-friendly services, which include things like being able to receive confidential services that are accessible to youth. Remember, youth can't drive. They can't necessarily go to an appointment. It needs to be accessible on public transportation or walkable to our youth. It needs to be low cost or no cost for youth because they don't have jobs and they don't have ways that they can pay for these things, and these can be expensive treatments. So making sure that our healthcare workforce is able to offer services to children in a youth-friendly way so that they can not only get the treatment but also prevent, hopefully, going down that path.
Yes, to both of those. And just piggybacking on that theme of supporting our workforce, we work in a field that has such a high turnover for staffing. I'm sure that we have all experienced that in the places that we've worked. And so with that investment, really investing in the systems we work within and creating the structures and routines to support our new employees and new staffs in this work, who's coming into the work and this is their first time having those conversations with young people, and how are we giving them the education and tools to sustain in this field. It is, I know that I am preaching to the choir right now, but sitting in those conversations is so difficult, and we have to make sure that we have our own self-care and the resources to show up the next day and keep showing up. And I think we have a lot of work to do in that area. Thank you. And then we know the value of peer support, and we have done a great job of initiating those services and resources, and we need to continue to invest in the very unique role of peer supervision, that I can show up as a supervisor for my social work colleagues, but my role as a peer is not how I show up in this work, and that those who are peers to be able to have that support around the unique services and peer supervision so that peers can continue to show up every day in this work is also really important.
So when I first heard this question, I'm like, well, goodness, everything can be improved, because it's so new for youth. The focus has always been on adults, and there's such a huge stigma for the youth. And like you guys said, when I help a youth and try to get them into additional services, what they hear is like, you just need to not do it. Just stop. Like, why can't you just stop? But on the other hand, if it was adult, they'd have everything provided. They'd have the education. They'd be maybe offered mat services, and like, it's hard to be on the last end because all y'all like said all these amazing things, and I agree with. Yeah. And like, I'm like, well, heck, what's left for me? But literally everything can be improved. Like the money, we can invest in our staff, we can provide more training, we can get creative on how we're helping these youth, because even when we do have systems, there's still going to be that one person who falls through the cracks because that system didn't work for that kid. So we need to be able to individualize. We need to be able to meet them where they're at. We need to be able to build rapport and have the time to build rapport when some places, oh, you can only meet with them for an hour. Well, that's not going to work all the time. So we need to be able to really look at everybody and meet everybody as a human, not just a statistic.
I think it's so great that you all are pointing out not only how we structure direct jobs, but also, and we know this work is hard for everyone, but also how our systems can make it so much more challenging for people to stay in these jobs, want to stay in these jobs, not feel burnt out. So I think that's definitely some food for thought for all of us. Okay, so the next couple of questions you'll notice we sourced from our audience from our last sessions. So they were curious to hear about your all's most effective strategies for motivating youth and their support system. Brooke, do you want to start?
Okay, well, I don't really have effective strategies for motivating youth, I guess, because there's no one thing, because it's all individualized. You need to get to know that person and figure out what intrinsically motivates them, because I feel like that is going to be pretty much the only thing that is able to be continuous, because you can't always bribe people or, oh, you get a treat, and it's not a dog. So really getting to know them, and sometimes it's their fish that's going to keep them going. Sometimes it's because they want to get their GED. Sometimes it's because they're tired of living on the streets. So whatever it is for that specific person, it's going to take time to find it, but I mean, that's why I'm up here, because I'm going to dig. So there's no one thing that I can say, oh, here's something for you. So, yeah.
Yeah, not only what they want and what they're hopeful for, but what are the barriers? And because we know that there's barriers to barriers for accessing so many of our services and resources. And so once we figure out what those goals are, what might be the things that they're worried about or just aren't attainable because transportation isn't available or gas isn't available, insurance is not going to allow payment for the specific program or resource they're looking for. And so it's really a robust conversation around not only is what are they wanting and hoping for, but let's plan and predict for the things that are going to get in the way so that we can be addressing those too.
So yeah, to piggyback a little bit on what you said and what I just mentioned earlier is making sure when we're motivating our youth, we have to understand what motivates them specifically, or what's taking away their motivation, so decreasing those barriers. So we've done lots and lots and lots of research in healthcare on how to get kids to want to use long-acting reversible contraceptives. There's been lots and lots of research in reproductive health in youth. There hasn't been a lot of research in substance use disorder in youth. But we can take some of those learnings, and we know when we asked youth why they don't come for reproductive health services, they cite the very things that we've been talking about: cost, concern about confidentiality, who's going to know, do my parents have to be aware, accessibility. And then not only that, but actual youth-friendly facilities. Am I going to go into a facility where there are older people? That 14 to 35 really speaks to me, because youth-dedicated facilities are really important so that youth can come and feel comfortable in the facilities that they're in and know that they're getting care that is specifically for them. Once you've reduced those barriers and you're looking for actual motivation, truthfully, gift cards. It sounds like a really silly thing. No, I kid, but also we work right now, we have lots of groups we have youth action councils at all of our schools, and these are peer-led groups that are dedicated to looking at how to improve the overall health of their student populations, and they come up with their ideas, they put their own projects together, and every single time we ask, what do your peers need? What do they want? How do you get them to show up? And it's the things it's gift cards, it's food, it's little, just tokens of appreciation that bring them on. A lot of times these kids want to participate. They just need a little bit of what's the carrot, what's going to bring them in. Now, is that going to get them into an actual treatment facility? I can't promise that. But we do need to invite them to the preliminary work to get them into these things. So, bringing them in and getting them comfortable with a provider, getting them comfortable with safe adults that can help to give them guidance and help them to find the resources that they need. We have to figure out how to motivate them by figuring out what they need, what they want. So I don't think there's any extraordinary things that need to be done. I think it takes creativity, it takes time, and it takes really figuring out what are the barriers and working to reduce those.
Yeah, so can you just repeat the question for me?
Yeah, absolutely. Your most effective strategies for motivating youth and their support system.
Okay, so I think there's a couple different sides to this. There's kind of like engaging in like clinical services and stuff, but the most successful strategy that I've seen and that I've been able to use is empowering youth to be leaders and to take on issues themselves and to take responsibility for those issues themselves. And what we know is that peer influence, right, peer pressure is a huge driving factor in behavior for young people, right? I can coerce my kids into doing something and they may do it because dad says, but if their friends are buying into that idea, that value, that behavior, then their internal motivation is actually like in alignment, right? 100%, and they're wanting to do it. And so that's what I've always kind of tried to do is as 4D's building its adolescent recovery center, right? We're looking for the youth who are taking high responsibility for their recovery, and they really believe in it, and they want to help other youth, and so then they're taking leadership roles, right? And they're bringing people into that, and then those youth are holding each other accountable, right, for their own healthy decisions and positive decisions. So we want to cultivate that in the youth and promote their leadership skills and treat them like adults, which people sometimes think that's weird that I say that, but whenever I've worked with young people, I've always talked to them like they were my peer, like they were my equal, like I would an adult, right? Like I would with one of the people I was supervising at my work. Explain everything to them, explain why, and empower them to make the decision, right? And so that's one thing. Giving them extra tools, right? Understanding what they need is really important as well. But what I'll say about like treating them like an adult is, I'm not just saying whatever you want is what we're gonna do, right? I'm challenging them to make critical decisions in their own life and to understand that they're in charge of their own life, and the decisions that they make today are gonna impact the rest of their life, and giving them those critical thinking skills that they're going to be able to use over the long term, right? And then I think about, okay, what are their support groups, right? Those are people at school, those are their parents, right? And so then we have to begin to wade into the relationship with the parents, right? And try to figure that out. And that's a mixed bag in my limited experience, right? Some parents are like real over the top, like me. I get real involved, get real crazy and weird in stuff, And then some parents are like real hands off, and they're like, here's my kid. I'll be back in like 3 hours. Can you have them like all fixed up for me? Because what they're doing is like a problem, right? So it's trying to find that balance of getting everybody on the same page, right? And then, there's different communities, and different cultures, and they have their own, details and nuances that you have to work through. And so I think for me, I have to not be afraid to be wrong and to have conversations and to learn at all times and be humble. But at the end of the day, if I can get the kids to take responsibility for their own life. And I think one way you do that is you help them see the value in themselves. I know for me, I felt undervalued. I felt worthless. I'm a white trash kid from Pocatello, Idaho, in a trailer park where you could turn a 1-bedroom trailer into a 4-bedroom trailer if you hung some sheets from the ceiling. Like that's where I come from, right? And so I felt very insecure about who I was growing up because I was poor. Until I got into recovery and people taught me that my worth was in my integrity and my values, right? And how I treated other people and how I operated in the world. And so I try to teach that to other kids too, like that's your worth. Don't worry about what the world says you are. You worry about who you want to be and how you want to live your life and what's the definition for yourself, right? And try to empower them to make those decisions and then teach them to be leaders and go out and recruit other kids. And so we've been seeing that start to happen at 4D, where some of our referral sources it's from kids recruiting other kids to come and be a part of what we're doing. And that's our ultimate goal, is to create that leadership culture where we're not telling them what to do. We're giving them tools and guiding them, but they're really driving that behavior.
I just want to sort of reiterate one thing that you really said, and also make sure that what my response was clear, that bribery is not the way to get kids into anything. Hopefully it didn't come across that way, but really finding out what they need to feel supported, what they need to get them into, and that may be extremely individualized, and what is going to drive and what is going to motivate them. So when I say there's not one stock answer, it's because there shouldn't be one answer, because every child is going to have a slightly different motivation. What's going to bring them in is going to be different for every single one. So really making sure that we are figuring out how to connect with these youth and understand what they need from us on an individual level. So I really appreciate that, because
we bribe kids too. we got pizza.
It has its place. It has its place.
Contingency management in our field in general as an incentive for behavioral change, but no, I got you.
Yeah. No, but I think it's. I hope everyone walks away hearing that we're going to fix this with pizza and gift cards. No, but I really want everyone to hear that it is a really individualized response. And so I think we really have to look at not what is the one thing that's going to motivate kids to come in, but how do we learn to connect with kids so we understand what each individual's motivation is.
Okay, thank you all for that. I am curious about this kind of piece that was, I think, embedded in the question. I would love to hear your all's thoughts as well, is kind of the piece related to family and the support system. Do you have any effective strategies for when they might be the barrier to services or engagement or motivation? I think, Tony, you talked a little bit to it, but I'm curious if anyone else has any other thoughts about that piece. Just, a lot of just keep trying.
This is a really hard one. This is hard, and I don't think anybody's cracked this nut completely. I can say not specifically for substance use, but when we have parents that are reticent to whatever intervention it is that we are recommending, the biggest thing that has helped us is to make sure that we are coming this from a family perspective, bringing the family into the room and understanding what their motivations are and what their values are and what's causing that block in their individual family. So again, I think it is individualized, but typically when we have a disconnect between a family and a child, we set them up with our behavioral health counselors so that they can work together as a family to kind of get on the same page.
So I just want to start by saying I don't work with families. I have my own children, 18, 14, and 6. But the one thing that I have done when coming in contact with families is asking what they have done in the past, what they're currently doing, and what they want for the outcome, and then asking, and how is that working for you? Because if they are resistant to compromise, to talk to their youth authentically and like on a one-to-one level, like, you know, we're in this together, and come up with a solution that works for both parties. But, you know, they need to be able to see like that what they're doing isn't working, but not also like, oh, what you're doing isn't working. They need to, you know, put the pieces together somehow. I just kind of give them a little push. But again, I don't work with families, so that might not be the right answer.
I think it's the right answer. Yeah, and I just think, what is the barrier? Like, it's just such a myriad of potentials, and with whatever that barrier is, that directs us and where we need to go. Sometimes I think about the families that I'm working with, and there's challenges at play, and that means that there's also a lot of people in their lives and a lot of people trying to show up and support. And for me, that highlights we need to find out ways to be working more collaboratively, and, you know, what message are they getting over here? And it's a little bit of contradiction to what they're getting over here, and how are they navigating that, and how are those partners partnering with each other, and how are we all like providing the big community hug to our families and making sure we're giving supportive messages that aren't contradicting one another or aren't duplicating work and services, because I think that we're at risk for doing that sometimes.
So I think what you said is the right answer. If there was a right answer, I think it is. And the name for that strategy that we put to it is motivational interviewing, and doing motivational interviewing with the client and the family to understand what is your actual motivation behind what you're doing and why. So you often in these conversations, the parent and the child want the same thing. They want to get to the same end point. It just may not be that they're always in alignment with how to get there, and through that process of interviewing them and understanding what their, you know, intrinsic factors are and what their belief systems are, a lot of times they end up coming to the same conclusion, not always right away, but having those conversations for us from that motivational interviewing. And I encourage everyone to look into MI training, because it is a really great way to affect change and to help people understand what their actual motivation is. It's not that you're changing their mind, it's that they're figuring out internally that this is where I start, and now I can see the path forward. I can now see through self-reflection and through these open-ended questions that this is actually how I can get to that point.
Yeah, so in my experience working with families over the years, when it comes to substance use disorder for kids, the first thing that I always do is, you know, I talk to the kid separately and I talk to the parents separately. That's all the first thing I do, because I want to figure out what's really going on. Usually I'm like, okay, let me talk to the kid, figure out if they're actually addicted and what kind of drugs they're using, try to get a scope of the problem here. Or did they try marijuana once and mom's bringing them in and wants them to like go to residential treatment or send them off to a wilderness camp for 2 years? And I'm like, hold on, you know, this person just needs some education. So I want to figure out what's going on, but and then I want to orient both parties to what we're looking at here, right? And if the kid's got a substance use disorder, then I'm really clear about what the path forward probably looks like, right? This probably isn't a one and done. You brought them here. This is going to be, you know, might be somewhat of a journey, right? Over the next few years, we're going to have to buckle in And, you know, that can look different for each family, right? Some families are like overly maybe giving and supportive to the point where they're enabling. And I know that's not a popular thing to say, but what I'll say is that they're not creating any accountability or structure, which the kid can't respond to, right? They just keep taking and taking and taking. And I'm not saying you should kick kids out of the house or whatever, but I'm saying we need to have some boundaries. Or it's the opposite, and they're like overly have too much boundaries, right, with the kids, and they're like, okay, you just go out on your own and figure it out and come back and talk to me when you're done. And so it's trying to help the families create kind of that middle ground, and then being really clear that, okay, if the kid is getting into recovery, right, that's what we're looking at, y'all have to get into recovery too. Like, not in the sense maybe you have to quit using drugs, but that often can be a problem. But what I mean is that, okay, we're all gonna have to work together to identify some sort of healing, and everybody's gonna have to work on it, right, together. Because as the kid begins to change, they're gonna need you to change, right? Maybe the way you parent, the way you support them, the way you talk to them, right? And so that's what we're gonna have to do. We're all gonna have to be willing to work hard, right? And most of the time, I find that parents are willing to do that. Sometimes there's a split. Like, mom wants one thing, the dad wants another thing, grandma's in the picture, kind of the backup, right? We'll send Tony to grandma when things get bad, right? And stuff like that. And so understanding that. And then also understanding that when I'm entering in to the family, there are real cultural components that I have to be able to be flexible with, right? Some families are not going to want to participate out the gate because they might not even buy into the fact that services are an option because they want to deal with everything in-house, right? And that's a whole different strategy, because then I need to build trust, right, with that family, especially if we come from a different culture, right? I need to build trust with them so that they'll listen to me so that we can work together, because the kid might run away from home and come to our center, and then the parents are pissed and they're threatening us, right? Like, you kidnapping our kid, you know? And I'm like, hold on, like, they came here because they want help, so we have to work on it together. And so those are kind of some of the strategies I've noticed that have worked.
That's super helpful. Thank all of you. Next question also came from our audience, from our day one. If you all could speak a little bit to the unique challenges of youth who might also be criminal justice involved, and how you work to overcome those, tips and strategies there as well.
Well, I think just by nature of the criminal justice system, it's punishment based, and so that there is an inherent fear and worry about young people being able to have those open and honest conversations about what's going on specific to their use, because it's the setup for consequences and not being able to break that loop. So I think that's one of like, just off the top, one of the most challenging pieces. And then I think, just to harken back to the answer I had to the previous question, that if a kiddo is connected to the juvenile justice system, it's likely that that's not the only system they're connected to, that there's other things at play. And needing to make sure that everyone is partnering and collaborating with each other is so important. Okay.
Yeah, this is a really hard question, because I think all of us really struggle with this. I think for me, from a primary care lens, is that we don't have a good connection. We don't have a good a way to get to these kids. The juvenile justice system doesn't have a lot of connections within the community. They sort of stay internal to a lot of their own resources and don't necessarily reach out. And some of that is, understandable based on the nature of the work that they do, and some of that is they are also really strained in their workforces, has a really difficult time keeping up with their needs. So we don't have a lot of exposure to the juvenile justice system and primary care, because we our leaders have not talked to each other. They have our leaders and our community need to come together to figure out how we can collaborate together and can help us to bring our resources together. So I think that this sort of starts at the top. Just from our very limited work with the juvenile justice system, one of the challenges that we've had is that the children that do come into our clinic often come in shackles, and that is upsetting to other youth. It brings real feelings of shame to the youth that's coming in. It's an automatic, these children come in so shut down. So I think we really have to figure out a better way for them to be able to access these treatments and services in a way that isn't as shaming, because they come in so shut down. So we have a lot of work to do with this, and I think a lot of that work starts at the top.
Okay, this may not be a popular opinion, but this is just my experience, okay? And there's some research to back it up. So if you look at treatment episode data sets, okay, and you look at from about 2002 to 2017, and you look at 35.5 million referrals to treatment, 33% came in from the criminal justice system. Another 33% were self-referral. I bet a lot of those were a part of DHS. And then 6% came from healthcare. Okay, 6% came from healthcare. Yet in our society right now, what we debate right now is substance disorder, is addiction a criminal health or a criminal justice issue or a healthcare issue, right? And it has been kind of pushed on the criminal justice system for a long time, and I think they've adapted to some degree pretty well. And in my 10 years of running 4D, I've had an easier pathway with partnering with the criminal justice system, whether that's going inside OIA, going inside the jails. I mean, I'm a felon, right? I'm a felon, and the prisons will do whatever it takes to get me inside the jail, okay, to get peers in there, because they know that we can help, right? But I have yet to be able to form a partnership with any emergency room where 4D can have peers inside the emergency rooms or inside primary care or inside healthcare to where we can go in and intervene on people. So I think we have a lot of work to do in passing the responsibility from the criminal justice system over to like healthcare or more interventions, or I've had a lot of trouble getting a real partnership with the schools, and I think that's why the recovery high schools have been developed, right? Is because education wasn't taking it on. So I don't want to sound like I'm beating up on other people and defending the criminal justice system, but I just want to say what my reality is. And so I think when working with the criminal justice system, what we've tried to do is say, hey, we understand you have an intersection with this problem. Let us come in and build relationships, and let us ease the burden so you don't have to do it. And let us get them in the community and show them how to be in recovery. And then we can circle back around while we're engaging with them, and we can defend them and provide evidence to them doing their recovery stuff, right? Make sure that they're not going to jail, they're not going to prison, stuff like that. And so that's been my experience. So I think the best way is to have linkages between whether it's healthcare, schools, criminal justice system, just some of these community-based services, right? Like 4D, we do a pretty good job with young people. Do we serve all young people? Absolutely not. We need a lot more services. The Miracles Club, somewhere that I went, they serve mostly African Americans recovery. That's where I went. That's where I got sober at, right? They do a really good job. They've got a ton of resources by Measure 110, and their community's expanding. They're training a bunch of African Americans to get into the field, and so I think we need more investment into some of these community-based resources, and then we need to really develop some partnerships that realize that long-term health really oftentimes happens in the community, right? And there's some interventions in some places, but we need to get people together when it comes to substance disorder, get people in recovery, get them working together, and I guess that's my time. Are we doing somebody's time in me? I'm sorry. But that's just been my experience, and I know it's not a popular opinion, but it's been my experience, is that you have to have multiple interventions and try to get people the help they need.
This is also bringing up for me, hearing you all talk, coming back to our day one of the learning series, where we heard about the work that PPS is doing to try to disrupt that school to prison pipeline for folks, and just that role that we talked about on day one of prevention and how we really can disrupt that cycle there as well. So thank you all. That's just creating some points for me. Okay, our last audience question before we open it up. So folks were curious to hear from you all how their teams might work together to best support youth, whether that's things like having a special place in their team meetings to talk about youth, or it's conferences, or kind of what strategies do you have for teams day to day?
Okay, so it's just listening to the kids. I mean, I've been a part of either the behavioral health system, the mental health system, and now like the recovery aspect of it, and there's always the adult agenda. And that, in my opinion, seems to be a big barrier because we all have our own egos and we all think we're right. And then a lot of times it can even be like the upper management putting requirements on your team. And then what your goal with the youth is gets kind of put to the side. So always being able to look at what you're doing, look at what you're being asked to do, and being able to prioritize with the youth in mind. I know we all have things that we have to do, mandated to do, and that's, but to help the teams just like, you gotta talk to each other too. You gotta support each other, because if you can't support each other, then it's gonna be harder to support the youth. You're gonna have to staff some hard cases. You're gonna talk about, the old Jimmy's doing this and I don't know what to do. And, being able to collaboratively help that youth instead of, all alone. I don't know. That's like just coming together, listening.
Thank you. Yeah, I would challenge everyone to just think, what does your workspace look like, and what does your organization look like, and what are the systems that are set up in place for, I will often think from that lens of treatment, just because that's the work that I do, but is there a treatment team model, or is there a team model that we all may be having our individual conversations with young people, and the confidentiality of that holds true. The details of those conversations get to remain confident, but the general themes as others are interacting with students, what is coming up, who else is aware of dynamics that might be happening for a young person? Are they telling me one thing because I work in a school? Are they telling a teacher something else? And as we start to pull these puzzle pieces together, we see a greater picture that gives us clues to how we can best be responding and supporting this young person and their families. So what are the systems that are in place where you work that allow those times together to just make sure that you're looking at the whole person that you're trying to support and what different dynamics are at play. And then there is the crisis and the traumas that come up in this work, and when they happen in big ways, what is the response of where you work to be able to support one another so that you can show up the next day and the day after that and next week, that there is that healing that can happen amidst the difficult things that we know just inevitably take place.
So from a general team perspective, and then I'll talk a little bit about a healthcare team perspective. From a general team perspective, I think the first thing you do is start having real conversations with your team about their biases and where their judgment lies and where they are putting up barriers based on those biases, whether they know it or not. So really starting to have those conversations and making it a priority to understand not only like where you personally are, but where your team, the general biases in your team of like, we haven't, we don't do this particular practice because that's the way we've always done it. Well, why? Why did you always do it that way? And is there perhaps something a little bit deeper rooted in there? So really exploring that and doing a lot of self-reflection. From a healthcare team perspective, we have to understand that kids are not just small adults. They are kids, and they have to have unique, specific, child-based interventions. And that's not to say you treat them as children, because if you treat a 17-year-old like a 7-year-old, you're not going to get very far. But you have to understand what adolescent pediatric care looks like compared to adult care. And secondly, prevention work in healthcare is not sexy work. Nobody likes to do preventative medicine, or it's not invested in, it's not talked about. Like, we all know hypertension kills and diabetes. We can treat those things, but we just don't invest in the prevention of those issues. And so when your healthcare teams are looking at how to support, you really have to look at and invest in preventative work, not just treatment work. And so having those conversations around, where is our energy really being focused? Is it being focused purely on, whether, just to go back to diabetes, are we just focusing on treating the diabetes in this family practice? Or, hey, do we actually have conversations with our kids before this happens? And we realized that education and prevention talk and anticipatory guidance is usually the very last thing that you get in your healthcare appointment, and it's usually just written on the piece of paper and you're sent home with it, and it's never even talked about. So from healthcare teams and how we support, we really have to look at preventative work as well, and making sure that we are putting an emphasis on that.
Yeah, I think, I'm like an advocate. I have been since I got into recovery. And so I think, what moment are we in time, right? And the moment we're in right now is there is a massive political and public debate on drug policy. Okay, and on the one side, you kind of have the Drug Policy Alliance, which pushed Ballot Measure 110, and their goals are to legalize and commercialize illicit drugs, so that you could buy illicit drugs like in the store, right? And then you have like another group of people where it's like, you gotta have the police lock everybody like up and stuff like that, or it's abstinence based only, and stuff like that. And it's this big debate, right? Then there's a huge debate around the intervention, right? Should cops intervene at all? Right? Should the criminal justice system play a role in that? And I think it's a great debate to have. And I have my own personal opinion shaped by my own personal experience and by research and what I see help people and working with people, right? But I think in that debate, what's being lost is the scope of the problem that we're facing and the resources necessary to address it. And the debate is principally in the adult system of care, which, like I said, I referenced the study from the Oregon Science Health Use University, which in my opinion is conservative, that said we're 50% under capacity for services for adults. There is even less for kids. And we are in one of the most permissive and liberal states when it comes to drug use, right? Oregon likes its drugs. I'll be real honest with you. We like our weed. We got so much of it. It only costs like $1 now to get anything you want, right? We've oversaturated the market. We like our little brews and our wineries and stuff. And so I think what I would say right now is the debate around intervention is very good and harm reduction is very good and abstinence is very good, right? That's a very good debate, but we can't let our elected officials think that debate and moving Measure 110 money around the margins is fixing the problem, because it is not respectfully meeting and addressing the issue at the scope that we're facing, right? And so we need a lot more investments, right? And those investments need to be tied to like also specialty services, right? Different sort of services that serve different sort of populations, right? And so that's what I would say is, if you can, pick up the phone, call your legislators and say, you need to invest more money into adolescent treatment. Because if you don't do that, right, unless you're a billionaire, you can't move the dial. And so the only way to move the political dial is collectively together. And right now there's a political moment to do that, and I would hate for us to miss it.
Thank you. We have some time to open it up to you all for questions. Just a reminder, or if you weren't here for the announcement earlier, due to our recording, we're going to have our lovely CareOregon volunteer, Ben, be coming around with the mic. So if you do have a question, please just raise your hand and wait just a second for him to get to you so we can pick your questions up on the recording. So, questions. I see one over here.
Hi, it's not really a question. I just wanted to tag on to the question around family support. So I am a parent. I work for Multnomah County Behavioral Health with youth and families, and a clinical social worker, and I have a young adult daughter who's struggled with substance use, and her addiction really spiraled out. Tony's been a great source of support for me and for her. And early on, the approach that I took was through this clinical lens, like, I'm gonna lecture her about high THC content weed, and I'm gonna make her sit down and listen to this NPR thing, that was on vaping and Juuls and all this kind of stuff. Like, I think about all the times, like, oh, we're cooking dinner together and I'm gonna play this thing, Yeah, so that was not working. She was a very intelligent person. She did not take to the lecturing. Don't get all social worky on me, Mom. So I didn't know what to do, and I thankfully, through word of mouth, I was connected to someone in addiction medicine, and he said, you need to learn craft. And so I kind of started reading about it, connecting with people who know about it. It stands for community reinforcement and family training, and it's an evidence-based way of supporting families. And until I found that, I was lost. And so once I started to learn that and started to practice that, I saw results. I saw the connection between my daughter and I get stronger. We were communicating more. I was learning about why she was using. I was creating a space for those conversations that I couldn't have before. And it worked so well. She got in and out of treatment. There were many times I texted Tony in wee hours, saying, help me get into her head. I'm trying to understand what's going on. But we really did have deep, meaningful conversations, even when she got out onto the street. It got that significant with the fentanyl crisis. So she's doing well now. She has 15, 16 months recovery. But I will say that without this approach, I couldn't have navigated. So I've been doing on the side, working with families and helping them with this approach and teaching them why behaviors make sense, how to be with your kids' ambivalence about wanting to use, not wanting to use, how to, the one size doesn't fit all. All of these concepts we've been touching on is part of this approach. And just seeing so many results. And so I recently, I don't know if I should be saying this, but with 4D at the youth center, I did start a group for parents. So for the youth, 14 to 17, to kind of start having these conversations. So it's craft. Stacey's also familiar with it. There's also another approach that's called the invitation to change, and that incorporates motivational interviewing and acceptance and commitment therapy. And again, I'm not trying to say, Tony said, when you do this group, don't make it too clinical. It's really about support. It's about normalizing. I see, when I can say to a family, I've been there. You can see it's like, it's okay. We're going to normalize this. We're going to remove the stigma. It's really about, I think, working with families. If you can take away the stigma and help them lean in and know that it's not something they did wrong, that's where you start. So just wanted to share that. Thank you.
While Ben's on his way over there, I think that's such a great point that I'm hearing as a theme again today, which we also talked in day one, is that stigma, right? And not just for the youth, but also for the family. Two different pieces, but work together so well. Yeah, go ahead.
Good morning. My name is Shelby. I work at a primary care office, a pediatrician's office, and my question is for you, Tony. Yeah, okay, so just like throwing it out there, theoretically, if you were to partner with the medical home, what would be like top 4 things that you would need from a pediatrician's office, like Pediatric Associates of the Northwest? Just throwing it out there, just casually, just wondering.
Okay, so I was student body president of Portland Community College, okay? And the reason I bring this up is that when I was there and I was student body president, I was trying to get the Allied Health Department to adopt a prerequisite training for 4 credits that was on kind of the pharmacology of addiction, science of it, but then also on recovery, right? To try to get people destigmatized before they went in the field in these different professions, so that when they met a drug addict, and a lot of times people can tell, like if you're a dentist and you can't figure it out, then like, I don't know what to do, right? Like, and so, you know, like, oh, what happened to your teeth here? You know, I lost some of my teeth. It's like, whatever. I'm like, oh, you know, but there's no intervention, right? And so I think the first step would be educating medical professionals on, 1, what is addiction, right? And then what is recovery, right? And then how do you get people involved in the recovery process? And I understand that it can be hard in the emergency rooms, because I went to the emergency room, okay, and I'm in the highest acuity of my disease, okay? I'm high on heroin and meth, and I'm stealing scalpels and other shit there, and they're just like, oh my God, get him out of here, you know, because I'm going crazy in there, you know? And I get it, but still, it's a medical condition, right? And so if I'm in the highest acuity of a potentially fatal disease, right, I should be getting treated immediately. I shouldn't be, you know, begging for help and not getting it and being kicked out. And I've been escorted out of the hospital more than once by the police, okay? So they come in and get you. So I'm in my highest acuity, I'm having an addiction heart attack, and the response is to get the police to take me out of the place that's supposed to help me. We have to reconcile that fact in our society, right? And so I'd say education, being able to identify, okay, does this person need some help? And then getting them to the places that they need. One cool thing about Measure 110 funding is, and I was a huge critic of Measure 110, okay, in the design of it, but one of the coolest parts about the funding is it uses marijuana tax money, which is not connected to insurance reimbursement, which means you don't have to have these pre-authorizations, ASAM assessments, all these bureaucratic things, right, to get to the level of care you need. And so some of these organizations, you could just call them, right? And we'd be like, oh yeah, we come down, we'll help you, right? Just walk in and we'll get you going, and we'll figure out the rest of the addiction stuff for you. So that would be another thing, developing those partnerships. Figuring out some way for the commercial insurance sector to start paying more. To your point about prevention, like nobody wants to invest in prevention, right? But it's evidence-based and it works. And I'm not talking about like, just say no. Like, well, those things, people like, they're like, that doesn't work. And it's like, well, some of that does work around education, but it's on a temporary behavioral change status, right? It's like how you see like, don't drink and drive right before Thanksgiving and stuff. Like there's a reason they use those strategies, because it's proven to work in the short term, but over the long term it doesn't. And so investing after school programs, parenting groups, stuff like that, I would defer to my preventionists on primary prevention, be real clear about that before I get in trouble from the prevention people about what I'm talking about. But I would defer to them on what to do. But I think, you know, SBIR, you know, screening brief intervention referral to treatment might be really good. But then, you know, just have conversations with those local recovery communities and those local peer-run organizations to say, hey, if we identify somebody and they want help, what does that look like? Can you come and meet with them and get them started on their journey, if that answers your question. Screening, brief intervention, referral to treatment. You know, you basically ask them questions like, hey, you got a problem, whatever, cool, let me get you over to somebody who can help you.
One resource that you might want to look into as a primary care office is Nancy Zink down at the Benson Health Center has worked to develop a practice guideline specifically for youth substance treatment. So it is, and she worked in collaboration with the OHSU Adolescent Medicine Clinic. And so she has built a clinical practice guideline that you could bring to some of your providers to look at and see if they wanted to adopt that, because she is happy to share that with anyone. I don't know if Nancy's here today. She likes to come to these things, but yeah, Nancy Zink at the Benson Student Health Center. Z-I-N-K, yeah, Zink.
Good morning, I'm Todd Nicholson, and I have two roles. I am the principal of Donald E. Long School in juvenile detention, and the second role I have is I'm the principal of our newest recovery school in the area, Rivercrest Academy. So thank you so much, all of you, for your discussion and your insights. The thing that leapt out to me the most was about coordinating and understanding what's going on inside like juvenile detention and with corrections. I can really only speak to the juvenile detention part. So it is a challenge even for me, and I'm located in the facility because the work is heavily siloed, and that county mental health does mental health, school does school, medical does medical. But one of the things that I'm trying to do, because of both of my roles, is to be a convener and to get these silos talking to each other. And it's a real challenge. One of the things that I don't have the ability to do presently is, the average stay for our students is 14 days. 14 days, that's kind of in and out. And that means some are coming in for a day or two, some are coming in for much longer time. So just by virtue of that, it's very much a crisis-driven thing. I don't get the opportunity to do discharge planning from an educational perspective with students at all, because they come in and then boom, they're just gone. And I have no idea that, okay, they pled or they, whatever. I don't know those things. So my offer is, and what I'm trying to do is help facilitate these conversations. So if you all are needing to meet with folks in juvenile detention world to try to make things better, I am happy to help bring the butts to the table so we can have that conversation.
Thank you for that. That is so needed and so valuable. I think we have time for one more.
So I'm actually the physician for Donald E. Long, and I guess that is exactly right. I didn't even know that you were the principal of the school. And I don't think people actually know what we've been trying to do. We are now doing withdrawal protocol with BUPE, and we are doing inductions. The difficult part is, one, nobody tells us when a youth is using unless we notice that they're going through withdrawals and they bring them into the clinic. So that's number one. Number two, it takes a lot of care coordination from our part for multiple reasons. One, we have to communicate with the juvenile court counselor, who has to talk with the judge to see where the youth is going. The reason for that is we have to be able to have a plan so that they're going to actually be able to continue the BUPE when they leave. Sometimes we have treatment centers that won't allow them on BUPE, or programs that they're going into the community that won't continue it. And so we have to be able to come up with a plan where they either are going to change the program that they were going to be court ordered to go to, or they're going to have to send them home instead if they're going to be on BUPE. That's been a really hard sell with the juvenile court counselors because they don't understand BUPE. And another thing is we've had to come up with our own protocols, because we're starting kids younger than 16. And so we had to come up, we were calling OHSU, we were calling UCSF, because we have to make protocols for the whole, juvenile detention system, and there's only two of us, a psychiatrist and myself. And nobody could really tell us what to do. And so we had to figure out how to do that on our own. So once we've come up with that, we cannot get community partners to continue kids under 16. I mean, we finally have Greater Circle that's willing to help us out, but they require kids to get into the clinic in order to pick up the BUPE or have, and our kids aren't often resourced enough to get into that clinic. So we're calling people in the community and they just won't continue the medication. And so, we can't send them out on that. And then last but not least is in youth, you really need parental involvement. And parents have to keep the BUPE and keep it locked up and make sure that they're able to give it to the youth and make it to appointments. And we have a very difficult time sometimes finding parents that are resourced enough to be able to do that. And so there are so many barriers to care. It's really challenging. I mean, we are in a unique situation where we have a lot of kids that come in and really need help, but in that amount of time, we can't come up with the care coordination that we need in order to safely get them on BUPE and have it continued.
Thank you for sharing that. That's great. we're at time. I know this is a great conversation. We always want to keep it going. These are always so hard. First, I want us to recognize our panelists. Thank you all so much. Yeah, it was great. Invaluable information and wisdom. So thank you. And then just one sec before everybody starts to file out here. So our 9:40 session, remember that's the 3 breakouts. So in this room, we will have Starting the Conversation, How to Talk About Drugs with Youth with Stacey. Downstairs in Hawthorne, we'll have Medications for OUD and the Foundations of Prescribing with Bradley Buchheit. And up here across the hall, we will have Harm Reduction and Youth with Juliana. So we will see everyone again for those sessions at 9:40. Thank you.